So at this point, I'm so happy to kick off the panel on food as medicine. It's a session with two panels. One on food as medicine research implications in communities affected by generational trauma. And then the next one will be on rural and frontier communities. Thank you, Michael, for being here today.
All right. So I'm really delighted to be part of this panel and helping to moderate it. So I'm Michael Meit. I am with the East Tennessee State University Center for Rural Health Research. You'll also see the logo at the top. We are also the Rural Health Equity Research Center. We're one of the 7 federally funded rural health research centers. I'm going to start at a really high level, and I'm going to talk about national data at the intersection of poverty and health. So really, really high. And then Jason Wesco is going to follow me, and he's going to slowly drill down. So he's going to then bring it to the state level and talk about how this looks in southeast Kansas, which is the poorest part of the state. And then we're going to drill down even further, and Kofi Essel will talk about the specific aspects of how this plays out relative to nutrition and food insecurity. And then finally, Adrienne Markworth is going to drill down to the individual level, and she's going to talk about the body's allostatic response to the trauma of poverty and food insecurity. So that's the goal. So let me get it started. So these are the social drivers of health. I know you're all familiar with these. I put them up because when I talk about the social drivers of health, I really focus in on one thing, which is poverty. In my mind, if you do not have good income security, economic stability, it's hard to have good quality education. It's hard to have quality housing. It's hard to have access to nutritious foods. So for me, if we were just simplifying the social drivers, bringing it down to poverty, at least to me, makes sense. Those other things are important, but addressing those are kind of, in my mind, somewhat band-aids for the bigger issue, which is lifting up our communities and bringing economic stability to our communities. So that's kind of the frame I'm coming from. I'm going to share a handful of slides. I'm going to go through these quickly, but to me this tells the story. So these slides compare data from the 2% of the richest counties in the United States to the 2% of the poorest counties in the United States. 3,154 counties in the United States, I believe. 2% richest, 2% poorest. This first slide looks at years of potential life lost, which is a standard public health measure on life expectancy. It's really how we determine the healthiness of a place, how long you live, how many years of potential life loss that are lost. And we see when we compare those richest to the poorest counties, there are 3 times more years of potential life lost in our poorest counties. People in our poorest counties are twice as likely to smoke. They're 50% more likely to be obese. They're half as likely to have college education. And then the one that's always the gut punch, the children in these communities are 6 times more likely to live in poverty. That's just comparing the richest to the poorest in the United States. And notably, I'm a rural researcher, but it's important to point out that poverty is what brings populations together when we think about health inequities. So when we're looking at these poorest places, we're talking about urban communities and rural communities where there's deep, deep poverty. At the county level, this looks more at rural communities because rural county level data is better for analyzing rural. Because of the wide income distributions in urban communities, some of that gets washed out. But this does exist in our urban communities as well. It's just at that sub-county level. So very similar, really, findings, I think. And it's something that really intrigues me about how do we bring populations together to think about how we solve these common challenges. Because I don't know if you've noticed, but things are a little divisive in our country right now. And often it is based on this geography, which I think is kind of a false dichotomy when we have people who are suffering in all of our communities. So there's something there that we need to figure out how to crack. So here's what I want to do. I want to take you to Minnesota. Anyone know why I'm taking you to Minnesota? So Minnesota, by the measure of years of potential life lost, is the healthiest state in the United States. So Minnesota's doing great, right? So this now is looking at kind of that same national data, but bringing it down to the healthiest state in the United States. the 5 richest counties and the 5 poorest counties. I don't know how many of you know Minnesota well, but you may notice something about these 5 poorest counties, which is that by and large, they are tribal communities in Minnesota. So we do see these intersections between tribal lands and poverty as well. So this is what this looks like in Minnesota. So between those 5 richest and 5 poorest, there's 2.5 times difference in years of potential life lost. Here's what I want you to see though. Minnesota, I mentioned, is number 1. So of course, those 5 richest counties are doing better, right? Where do you think those 5 poorest counties show up in terms of the 50 states? It's actually 51 because they include the District of Columbia. Where do you think they show up? They show up around 49, okay? And when you look at all of the states in the country, the poorest counties in Minnesota are on par with Mississippi and West Virginia. And most people in Minnesota don't know that there's a Mississippi in Minnesota. And that to me is what's really powerful when we think about the impacts of poverty. Even in the places that we think are doing well, we have people who are struggling, and we have communities that just are really falling behind. I do this in states all over the country. It's really interesting. Minnesota is my favorite because I think it's just so unexpected. But when you do this in Mississippi, what you're going to find, not a Minnesota when you look at the 5 richest, but the 5 richest are doing pretty well by comparison. They're around Ohio and Indiana. So they kind of fall in the middle of the country. If any of you are interested in this analysis for your states, let me know. I end up presenting this at a lot of state rural health meetings, and it's always fascinating just to see kind of where those distributions fall within states. So this, and just linger on this a little bit, this is now looking in Minnesota at the health outcomes between those 5 richest and the 5 poorest. And as you go down the line, you're twice as likely to die from heart disease if you're in those poorest counties. I'm sorry, 2.5 times as likely. You're twice as likely to die from cancer, COVID, cerebrovascular disease, lower respiratory disease, all the way down the line. So this poverty that we see leads to these health inequities that we also observe. So then just last thing I want to touch on, I was asked to talk about diseases of despair as well. How many of you are familiar with that terminology? So I see some hands. So I'll just tell you a little bit about it. So diseases of despair or deaths of despair, this was a term that was coined by a couple of health economists at Princeton University. It caught fire. Some people love the terminology, some people hate the terminology. I'm one of the people who does not like the terminology, even though I end up doing a lot of research on this. I prefer to think of these as diseases of neglect. I'm going to talk about that a tiny bit in my last slide. But essentially, there are 3 primary causes of death: overdose mortality, suicide, and alcoholic-related liver disease. And what these economists observed is that these were disproportionately affecting white working class populations, which is a lot of Appalachia. So we have done this ongoing study for the Appalachian Regional Commission looking at these deaths of despair. And I'm only going to really share one of the slides with you because as we talk about intergenerational impacts, to me, this is the slide that tells that story. So what you see here is deaths of despair for males and females age 15 to 64 by age bracket. And what you see is that for males, you are 50% more likely to die from these causes of death if you are between age 25 to 44. And for women, the disparity is even greater. You're 60% more likely to die from these causes of death if you're 25 to 44 female in Appalachia compared to the rest of the United States. That's important because those are people in their prime childbearing and child-rearing years. The impacts that the crisis of opioids and these other deaths of despair has within our Appalachian communities, but more broadly within our rural communities, affects the children in our communities. It leads to these intergenerational effects that we observe, leads to adverse childhood experiences and trauma that we see in our communities. Anybody who's interested in any more of that, I've got tons of research we've done on this. I'm always happy to talk about it. But this is where I do want to end because to me it's really important to reframe how we talk about these things. So I've been trying to push to really get people to start talking about these as diseases of neglect. Unfortunately, I am not a health economist from Princeton, so it has not caught fire, but I'm persistent. I am persistent. So when we say diseases of despair, who takes the blame for that? It is the individual because they are feeling despair. These things are happening to them because how they're feeling. And that's the wrong frame. We have neglected these individuals in our communities. Jobs have been hollowed out in their communities. When you come to my region, when you're in Appalachia, almost exclusively individuals and communities have been impacted by the loss of mining jobs. That may be good long-term for our environment, but it's not good for the individuals in those communities. When those companies left those communities, the communities were gutted. Everything closed around them. The hospitals closed, the businesses closed. As these communities shuttered and there was lack of opportunity, substance use really started to perk up and all of these other consequences. We neglected people in these communities, which is why these things happen. And that's really, I think, the frame that we need to bring to this, because it's now on us to also figure out how do we reinvest and rebuild in these communities to help lift them up. So I'm going to stop there. Here's my contact information. I'm always happy to talk to people if they're interested. And with that, I'm going to hand things over to Jason.
Yeah, well, thank you. Hope you all can hear me okay. The context was really incredible, especially as we think through the challenges in Southeast Kansas. And Southeast Kansas is very different as from what people think of when they think of the rest of Kansas. We are much more Appalachia than prairie. Our history here is built on the extraction of natural resources, most notably coal and heavy metals. And that has created generational poverty, low educational attainment, poor health outcomes, all the things we've been talking about. And on nearly every map that compares regions, whatever the bad color is, we are that color. And so now, as opposed to mining and exporting coal, what we're exporting is our kids. So population loss is a significant issue for us. The history of the community health center dates back to the very early days of Pittsburgh, which was originally called New Pittsburgh, no H. We're very proud of that, after our namesake in Pennsylvania. So in 1903, the Sisters of St. Joseph founded Mount Carmel Hospital as a place to care for the folks who mined coal, who were largely European immigrants and African Americans from the South. And we're very fiercely proud of that heritage. But we are not a faith-based organization, but we're very much of the belief that we together and as a healthcare organization can help be a hub to solve some pretty tricky community problems. So our more recent history is about 100 years after that, when a group of visionaries in our community here in Pittsburgh came together to address childhood poverty. Unfortunately, we still lead Kansas in childhood poverty. About a third, not about, almost exactly a third of our children in Pittsburgh are born into poverty. More than 2/3 are born into Medicaid. But what they knew was that for those kids, developmentally appropriate childcare was the thing to do. So they created a place called the Family Resource Center, which brought together many resources in the community in addition to childcare. And a key component of that effort was healthcare. And the Community Health Center of Southeast Kansas was born. That was 2004. So we're just about 20 years old. And since those early days, we've really broadened the work we do and deepened it. So we're the largest community health center in Kansas by a significant margin, and one of the largest of the 1,400 in the United States now. We employ about 1,100 individuals. Our average salary is $60,000, which is very important to us. Some of our friends, we have a couple of Becky's and Amber and Audrey and Sean, who's a mutual board member there with you today, and I'm sure you've heard from them or got to talk to them. But of those 1,100 folks, they work in clinics across our region, they work in schools, they work in jails, they work in community centers, and we even have folks who work in Oklahoma, where we have a couple of locations. So we provide a very broad array of services. We deliver babies, have an educational program that includes family practice residents, pharmacy, walk-in care, physical therapists, dentists, addiction counselors, and on and on and on. And we're very proud to say that we've done that in the poorest, most underserved region in our state. And so we believe if we can do it here, it can be done anywhere. But from those very early days, our focus was not just on health improvement, it was on economic opportunity. It was on building and sustaining communities and believing that healthcare should play a bigger role in communities and not be, as we now see in a very frustrating manner, an extractive economy in rural America, where wealth is taken away from us and where large systems from urban areas essentially just shut down access to healthcare when the numbers don't make sense anymore. And we, in many cases, have stepped in to preserve healthcare in our region. We've lost 3 hospitals in 7 years, and we have preserved as many of those resources as we can. But even all those years ago, when we started so humbly in a 1,500 square foot trailer, we never believed that our services were kind of, good enough for who they were for. And so today in our region, we take care of everybody. We take care of the richest people in our community and the poorest. As I mentioned, we deliver babies, and we're about to open in 2025 a hospice, so people have a dignified place to make that transition of life. And so this broader role has really infused strategic planning. And 6 years ago, we really understood that to make a difference in health, we can't do that in 15 minutes in an exam room or in a dental chair or even in an hour therapy appointment, that we have to get to those larger social determinants, of which I don't have to explain to you all. But understanding that that was a monumental effort and not necessarily core to our mission, we created a subsidiary called Building Health. And that work is around housing, transportation, and food to meet what has become our de facto mission, which was stated by the foundress of the Sisters of St. Joseph, to do all the good we can in all the ways we can for all the people we can for as long as we can. And so we're really pleased with where we've gone with Building Health. We now operate Caravan, which is both general public transportation and also non-emergency Medicaid transportation. We're about to build our first affordable home. The foundation is being poured in February in a distressed neighborhood near where I'm sitting today. And as you've heard a little bit, we have healthy food program. We have food in our clinic, and food is medicine. And so clearly, when you're living this every day, this work, as a healthcare organization, you have to view your role as broadly as possible. So this is very dear to us because these are our neighbors. This is our family. These are the kids my kids go to school with. And so we have had to take a broader role because we have found, frankly, that others are not. And so we draw inspiration from many places, from our history, from the people that are here, occasionally surprising voices. So you may not expect someone from Southeast Kansas to talk about Rumi, the Sufi mystic poet, but I'm going to do that. And he said, "Be the one who, when you walk in, blessing shifts to the one who needs it most. Even if you've not been fed, be bread." And so what we're trying to be for our communities and our people and our staff is bread. And that's what I've got to share with you all, wonderful people.
Oh, the green button. So if you see the green light, that means it's on. Red light means it's off. All right, so I'm gonna give my dad joke and get into this. So my dad joke was going to be that Chris and I, well, I've never been here to Kansas before, but we're both from Arkansas. Yeah? No. Okay. All right, so yes, we're from Arkansas. Anyway, so let's go ahead and dive on into this conversation. Okay, mic drop. Okay, so I have nothing to disclose today. Let's go ahead and dive on in. So what am I talking about today? So a little bit about my background. So I am a community pediatrician by training. And for years, I've worked in Washington, D.C. in an primarily urban setting. In this setting, I've had an opportunity to work with a number of different kids. I work with kids from the age of 0 all the way up to 21. I want to give a different sort of framing for our conversation today. In the environment I work in Washington, D.C., we work in a very historically and economically marginalized setting. The highest rates of food insecurity, the highest rates of poverty, the highest rates of diet-related chronic diseases. But I really appreciate this angle of not only looking through a deficit lens, but also understanding through an asset lens as well. The same community I work with also is incredibly resourceful, incredibly passionate and creative and innovative at the same time. And it's an honor and a privilege to work alongside this community. And I want to provide today a little bit of a different framing for our conversation. Typically, when we talk about food and food as medicine, we think primarily through the adult framework, right? But here we're talking about generational poverty. In order to talk about generational poverty, we have to think about the next generation. So I want to think about children, but not only children, I want to really focus in on that young children time frame for our conversation today. So I want to give you an example. Here's an example of a family that, okay. Anyway, there's a family. All right, so here's an example of a family with a young child. Let's say this 4-month-old child here. This 4-month-old child is, living in this household that is experiencing food insecurity, let's say. And if this 4-month-old child is living in a household that's experiencing food insecurity, what does that look like for this family? What does that look like for this child? What does that look like generationally? Financial hardships, food insecurity, what does that look like in this community for this family? So to be able to understand this, I want to sort of take us through a pathway, a trajectory that I sort of see on a day-to-day basis with families that I work with in clinical spaces. So typically when families are having a sudden financial hardship, they describe a few things that occur. The first thing that tends to change when a family has a sudden financial hardship is their food budget. Right? We all know that, right? The food budget is so flexible, is so fungible. So as a result, when a family has a sudden financial hardship, they'll start to adjust that food budget and change what they're eating to help sustain their household, right? So when we think about this trajectory, a sudden financial hardship may hit, the first thing that I hear my families talk about is this concept of food anxiety, a constant perseveration, a preoccupation with where one's next meal is going to come from. One of our colleagues out in California, Dr. Hilary Seligman, she describes this concept of a decreased cognitive bandwidth. The ability to shift and focus on many things becomes hindered, restricted because of this toxic stress that we'll hear more about in a few minutes as well. So this is something that we tend to hear about. The ability to focus and plan ahead, plan for months in advance, meal plan for weeks in advance. Sometimes that hindrance is there because of this toxic stress. Now, after this occurs, what then happens after this family is trying to cope more and more? The next thing that they will describe is a decrease in the quality of food. We typically call that a monotony of the diet. The diet becomes very monotonous, very simplified. We tend to see the same foods being purchased over and over and over again. I know that if I purchase these fruits and veggies that we've heard about in the stores that sometimes won't last as long, that I won't get the same use out of these foods. I know that I am trying to avoid waste at all cost. And as a result, these items may not last very long, so maybe I won't lean towards these subconsciously or consciously. I know that if I buy these foods in particular, that these children will eat these foods. If I buy that kale and quinoa bowl that my doctor told me to get, I don't know if they're going to eat that. The experience of waste is too stressful, and thereby I may not lean towards those foods. In addition, when stress occurs, what ends up happening? The body tends to gravitate towards foods that we consider ultra-processed as well. Higher in sugar, higher in salt, higher in fat. It's kind of like a pop-off valve. It relieves stress by leaning towards these foods as well. So we see the desirability of foods changing, the variety of foods decreasing, the quality of foods start to decrease as well. The next step that occurs, of course, is the quantity of food begins to decrease. We all know, we see caretakers, parents, they love their children. So what are they going to do first? They'll eat less first so that their children can eat more. The vulnerable members in their home can eat even more. And then lastly, when they can't hold on any longer, children start to eat less. And when we see that, we know we're at an extreme of the experience of food insecurity. But what I want us to know and understand here, when I talk to my colleagues, I say, hey, I see all the way down this path that children are affected by a decreased food intake. But I don't want you to believe that children are affected only at the end of this journey. When you have food insecurity, financial hardship in the home, you sort of see this turning up of the tension and the stress in the household. And as a result of that, this whole journey, there's a palpable and toxic stress that we will talk more about as well. But with that palpable stress, this whole journey, children experience that stress through this whole journey. So these are important concepts to understand when families have sudden financial hardships, and these things cross over urban, suburban, rural populations as well, and it's important to realize that. My last slide, I'll close out with some take-home points. So a few take-home points I think it's important to keep in mind. Eating patterns, toxic stress that occurs in childhood tracks into adulthood. We have to understand that caregivers in households that experience food insecurity often offer a more pressurized feeding sort of approach. Why is that? Again, we don't want to waste those foods. You better eat that food on your plate, right? The idea, I'm in a lot of circles now, and we always talk about, hey, stop telling your kids to finish their food, to clean off their plate. That's not a good habit. Come into the environments that we work in and we grow up in, and the reality is that's not the same conversation. Why? Because the privilege of waste is something that everyone can't experience and can't have the privilege to have. It's important to recognize that the overall diet quality in households that experience food insecurity and financial hardship is poor, and also there's a lot of anxiety around wasting food. We must support caregivers by keeping in mind that supporting resources that allow them to reduce the anxiety of waste, while also at the same time helping them to improve behavioral change, is really an important piece. So when we talk about this food as medicine piece, it's really important to meet our families where they are, right? Really making sure we're supporting with meaningful opportunities, increasing autonomy, purchasing power, so individuals can then make those decisions that they want to make for their household. But at the same time, we talked a lot about the literacy and education. That combination is critically important. And the last point I'll make is this: just being sensitive about the challenges and hardships that families are facing. Making sure that, again, as I mentioned before, meeting families where they are, walking with them alongside them on this journey to improved health. It's not creating this esoteric place of excellence and saying you need to meet me here, but it's, again, meeting individuals where they are, recognizing that individuals typically are trying to get enough food first before we start thinking about novel instrumental foods that are going to transform health. So those are important things to keep in mind. Thank you all for your time, and I can pass on.
This is a stressful thing about going last on like really good panels. You're like, oh, maybe I should say that. Maybe I should say this. So we'll see if I can keep it focused here. So first slide here is, wanting to take this conversation in food as medicine out of a really transactional place of wanting to put a medical model on something that is not actually inherently medical, right? And so I think that's always a danger in the language that we're using when we're describing this particular, whether it's food as medicine or food is medicine. It still is a little unsettling when we consider what food actually is in community, or what food actually is like in our own human life, right? And how adversity can get in the way of that. I think the next slide, I don't even remember what. You have the clicker up there? Oh, I do? I do. Okay. So when we think about food, there's some great research on the meaning of food in life that breaks it down into, these 5 different domains. And when you actually track this, how people respond to their alignment with these different domains, what you find is that their alignment with the health domain is not necessarily aligned with their health behaviors, right? It's more of like the broader multidimensional understanding that people have of food in their life tracks better to health habits. So when we focus a lot of our nutrition security efforts simply on health, healthy foods, nutrient-dense foods, we may be missing an opportunity to actually build health habits by recognizing that our human experience with food is much broader than simply what's in the food from a nutrient standpoint. So this is helpful when we want to think about designing interventions, and also like what do we bring into this space as a researcher, as a practitioner, as a community implementer, to have that internal calibration of the meaning of food in our own lives, especially if you're somebody that looks at this and says, like, yeah, I'm pretty high on health, I'm a health researcher. Maybe a couple of you have high health if I were to ask you to take this survey, which is fine, but how does that interface with people who are high social and they see themselves primarily as a caregiver, somebody who feeds others and doesn't spend as much time thinking about their own health habits, which maybe you were getting a little bit at in the last conversation, right? Is as caregivers, we're often more focused on the people that we give care to. So thinking about this multidimensional relationship with food, well, this is a great goal, right? If we can all take these kinds of surveys and have the luxury not only of waste, but the luxury of an aesthetic perspective on food, the luxury of being able to eat together in celebration. And so those are the other things that are eroded, right, by food insecurity. It's not just the quality of our diet or the quantity of our diet, but the way that we can use food as instrumental in building our own communities. So what is something that gets in the way of that multidimensional relationship with food? One of those things is trauma. Okay, what's trauma? It's a word that gets used all the time, right? I mean, I have kids and they talk about trauma on TikTok and how it's used, in every conceivable situation. So maybe we just define it real quick here. It's sort of too much too soon, right? As our bodies are stressed, we can't turn off the faucet of hormones flooding our bodies, right? And then it causes damage, like actual biological damage to our cells. It's not something that's living in our head. It's not a mental health issue. It's an actual biological change that we experience when we undergo stress over a long period of time. And it mostly affects emotional regulation, which is our ability to experience our emotions without them kind of overtaking us, right? And we were just hearing about this feeling of stress when we have a food insecure period. I was once running, did everyone ever remember that documentary that Share Our Strength did? I think it was called A Place at the Table. Well, we were doing a video screening of this in El Cajon, California, many, many years ago at like a community library. It was a very kind of emotional documentary, followed families and children experiencing food insecurity. So the lights come up in the library, and we were taking some feedback from the audience, and this woman stands up. She was probably in her early 80s, just tears, right, streaming down her face. She was food insecure for 3 months at 13 years old when her father lost his job. Did not have any other experiences of food insecurity except for that 3 months when she was 13 years old. So 70 years later, this woman was still moved to tears because of that personal experience that she had with food insecurity. It was not a chronic thing in her family. It didn't matter. It was so fundamental to her experience of safety as a person that it, had this kind of damage. So it is a neurobiological response. Too much, too soon, too fast for regulation, right? We're built for stress as humans, but we can't keep up sometimes. So it's just so a lot of these biological things are appropriate given the situation, right? It's a biologically appropriate response to stress. It looks like poor health behaviors. It looks like poor emotional regulation. It looks like frustrating thing for healthcare practitioners or community educators. But it's actually like, oh, your body's working. So this feeling of profound unsafety is at the root of this. And when you think about those social drivers of health and you think about social connectedness and you think about loneliness and isolation, that's kind of why I asked the question earlier today, just about there's a lot of other things that promote health besides just, nutrient quality. So a trauma-informed approach is asking us to understand kind of what lies beneath the iceberg of some of these behaviors that we see, to realize and recognize the existence of trauma in our communities, but also of resilience. So what are these factors that we can leverage? It asks us to understand how we would put together programs that are responsive to this reality. A deep understanding of trauma and resilience, I think, is necessary to design food as medicine or any program. And then I think it also asks us how we want to build our organizations and how we want to build ourselves as people working in this space. Because this is part of the entire human experience. And we know that organizational trauma is incredibly prevalent in the nonprofit sector, intergenerational trauma, community trauma. The original research, of course, was done on individuals, but since then, it's been broadly applied. And I think that's where we see the impacts of poverty, because the original research was done with middle-class San Diegans, from my hometown, right? Dr. Felitti is San Diegan. But since then, it's really expanded into all of these different adverse experiences, which of course we see many of these are exacerbated by poverty. And many of these are intergenerational experiences for people. So when we think about food behaviors, and we think about the ACEs pyramid, and this is kind of the new ACEs pyramid, right? The one that people are using now, where we see these historical and generational traumas really at the base. So what does that allostatic load and disruptive neurobiology look like in terms of health behaviors, right? In terms of all this stuff that we're worried about. This is all tied together. So we can think about body fat, gut-brain circuitry, disruption, not feeling full, not feeling hungry, not knowing what you're feeling. That sort of intuitive eating messaging just doesn't have anywhere to land. Damaged metabolism, people that are eating the same thing gain weight anyway. You see that a lot in domestic violence survivors. And then the coping and adoption of risk behaviors, which is often where we come in, right, as health educators like me, just trying to change those behaviors with education, right? If you know better, you'll do better, which is not the full picture. And then, of course, the burden of that disease to stress, which we have seen all day today in terms of looking at higher than average rates of chronic disease and early death, of course, which is where this pyramid, unfortunately, ends. So just an invitation for all of you to think about a trauma-informed approach helping you to build research projects or interventions that take advantage of the resilience factors, but also have a nuanced understanding of trauma. That's it.
All right, so now we do have plenty of time for Q&A. Anybody have any questions? Yes.
I want to thank everyone for the incredible presentations. Very inspiring, lots of notes and pictures taken over here. So I'm a food security researcher primarily, and one thing that intrigues me about many of our current food as medicine models is that the gateway into some of those resources is through screening, for example, for food insecurity, for current food insecurity or risk of it. And, you know, as you were talking about trauma-informed approaches, I was reflecting on some of the qualitative work I've done where we were trying to take a very purposive sampling approach. Long story short, we had a group that was, we knew had either chronic or episodic food insecurity in the past year, and another group that hadn't. But lo and behold, in our conversations with the non-food insecure group, they had often had childhood historical experiences with food insecurity, and we were having just as poignant of conversations with that group, right? And so, you know, as we think about our resources and I guess screening for and designing pathways to these food as medicine models for our communities, you know, how do we need to think about that? So it's kind of a broad question, take it where you will, but I'm thinking about that screening mechanism because I think that's been so pivotal to the models I've worked with.
I think that, great question. I think food insecurity is one avenue or one aspect of using food as medicine as a tool to address. It's just one of those areas. But I think you can think about food as medicine to address a variety of other things as well, right? So we're now talking more about this concept of nutrition insecurity. Where does that fit into the conversation? We have groups in the room now who've been really developing new screeners to think about that and think about that in a whole new way as well. But also diet-related chronic conditions, diet-sensitive conditions as well. Could we use food as medicine as a tool to engage those a little bit better as well? Working in different settings around the country, when I see screening done around food insecurity, oftentimes, you know, one of the more common tools used is like the hunger vital sign, right? The 2-question, easy-to-use, validated screener that comes from the gold standard 18-item tool the USDA uses every year. Oftentimes, people are often using the dichotomous variable of yes or no, which is actually quite hard for individuals to respond to. So basically, in the last 12 months, we worried whether our food would run out before we had money to buy more. And then something similar for the question 2, yes or no. The question was never designed to be asked as a dichotomous yes or no. It was designed to be often true, sometimes true, never true. You can even ask, don't know, refuse to answer. Because so many of us are using the yes or no dichotomous variable, whether verbally or written, it oftentimes will spark too much stress for that individual and that family to say, hey, why am I going to say yes or no? The stress here is too high. If I share what's going on in my home, how do I know this nurse, PA, doctor, whoever is not going to take my child away? I'm thinking through the child lens. I can't share this with you all. The often true, sometimes true, never true, don't know, refuse to answer gives them more flexibility. Most people will say sometimes true, right? Sometimes true is a way that they can answer and really save face, preserve dignity, preserve their humanity, while at the same time seeing, hey, is there really anything, if I have this trusted relationship with you, is there anything that you can then do to respond? I think that's an important thing to mention, and that's kind of a sidetrack. But I would also add to that when we think about engaging food insecurity using screeners, it's one way of doing it. Honestly, it's trying to maybe medicalize it a bit, maybe structure it and formalize it a bit. If we use our own tools of bias that we learn in our clinical training, that's not going to get at it either, because families won't present with food insecurity in a very visible way. So the screening tool is one of the valuable tools that we can use. I think also engaging with qualitative metrics, also in trying to figure out, are there other ways that we can do that, is going to be the future of this. But for now, because if you're screening in medical systems, you have to figure out a way that we can ask those right questions to figure out who needs these resources now versus who doesn't. Food insecurity, I just think, is one of the elements that we can use to do that. I'm sorry, one more thing, and I'll be quiet. Mm-hmm. The last thing I'll say is that with screening for food insecurity, I think that it was good. It left me. It'll come back. But basically, that's what I'm thinking. It doesn't have to be only food insecurity. If you do use it, you can use screening tools, but hopefully as we engage more in this conversation around food as medicine, it doesn't just have to be using food insecure. If you're food insecure, then you can get these benefits of these programs, because there's so many other things you can look at.
I just want to provide the other side of that outside of research, but like in California, for example, we have CalAIM, which is our 1115 waiver. And the challenge there is that the criteria is, first of all, not food insecurity. So that is not a screening. It's not intended to be a food insecurity support. If you look at like a county like Alameda County in California, they're blending and braiding their funding so that they can pull in CalAIM funding as well as other funding so they can use it as food insecurity. But a lot of this in the way that it's going to be institutionalized is really dependent on how these initiatives are being funded. But the second thing is it's highly dependent on the payer and what the payer's decision are about eligibility. So if you're a health center working with Medi-Cal or Medicaid patients, and your patients have different payers, they're going to have different eligibility for what that food as medicine is going to look like. So as a practitioner, as a health center, you have to be doing a lot of jujitsu to figure out, like, what are you eligible for, who's your payer. So I think that some of the research, because y'all are researchers, like, it has to be on the system of collaboration in the healthcare setting about eligibility and doing it. Because I think if we stay too narrow, it's like, okay, this group of people benefits from this, but it's like, well, what is the effect on a broader community where you have so many different ways of being eligible and so much miscommunication between providers and the payers? Like, they're just, right now, at least in California, there's not a ton of consistency among the payers. So it's very difficult to work in. So that is where I'm interested, is like, what is the impact of that confusion, both for the individual experiencing the healthcare system, as well as the providers who are trying to do these referrals. Because it's really not clear, like, what research we need, because just lack of consistency.
Just going to add one more thing. I didn't mention this, and I should have mentioned this before. So I transitioned out of a career in academics in about the last 6 or 7 months into the payer space. So I am now the Food is Medicine Director at Elevance Health. Elevance Health is previously known as Anthem, a large payer, 47 million members, commercial, Medicaid, Medicare. We think through all those lenses. Coming into this space, I was coming from a clinician and academic space. What I've learned being in this space is that, yes, there are decisions that are within the payer's purview, but a lot of this is also policy, right? So what policies are in place that are allowing states, managed care organizations to be able to move forward on some of these provisions as well? It's not only at the payer level, you have to go upstream and think about those as well. So the advocacy is not only, hey, state, or hey, payer, hey, state, it's also thinking through a federal policy lens to improve what happens downstream as well.
Mm-hmm. Yes, go ahead.
Hey, this one is for the economist and for Jason, because I see your name up there, so I don't have to cheat and pretend like I'm going to call you the clinic director. Really quick, we're asking you to force policy solutions and economic solutions into a food as medicine box. That may not be the best or only solution for the communities that you guys are serving. What else needs to happen, or what should food as medicine look like to help your patients and to help those communities in Appalachia?
Well, for me, what I would say is we've had a very significant focus on community health workers. We now have about 70 in our system, and the relationships that folks develop is a great pathway into connecting people to food and other resources. So that's been one important strategy for us. The other strategy for us is here in Pittsburgh, we operate a food bank. I mean, we fed about 25% of the county this last year. And so in other ways, it's start with food and develop a relationship. And in other avenues for us, it's screen people in the clinics. And in other ways, it's have people who are from the community identify those opportunities for us. So we do it, and we do it other ways too, but those are kind of the main focus for us on identifying people in need.
Yeah, and I guess the other thing that just really strikes me thinking about this just from that Appalachian perspective, and this is true all over the country, but food is culture too. And in Appalachia, we do have a very strong historic food culture, and I think there may be avenues to tap in there as well to really engage with people at the community level, and our communities are very engaged. The other thing, just hearing some of the comments around policy, the other thing that just really strikes me, and it's something I just want to put out there almost as an invitation. I mentioned that we have one of the 7 federally funded rural health research centers. All of those centers are funded by HRSA, the Health Resources and Services Administration, to do federal policy level research to affect rural communities. We look for ideas all the time on what are the topics that we should be exploring and researching. HRSA likes those to be actionable to HRSA, which I guess is the big caveat. But if you have thoughts around research that we could be doing to explore these issues in rural communities, let me know. The other place to go is the Rural Research Gateway, which is ruralhealthresearch.org. All of the centers are housed there, all of their information, and you can reach out to any of those centers as well. Any other questions? We have a few minutes left. Yes, please.
Another really broad question. Given all that you've said about the environmental impacts on things, I'm wondering what any of you think about the whole precision medicine, which is now moving into precision nutrition, and how that might relate.
Please.
I was like, anybody else? I think that precision, I think that's the future. I think we're trying to figure this out, and I think there's a lot of opportunity there. It just is going to take more time. Hopefully, with precision nutrition, with precision medicine, we don't see worsening inequities. And that's the thing that we worry about more than anything else, right? So with having this insight and knowledge about what works best for you, how do you then access those resources to then be able to improve one's overall health with these tools? Is it going to cost an arm and a leg? Are there going to be new vendors out there that are now creating these price margins that now you can't access? Are payers, or in the sort of, is policy and the payer space going to be able to invest in those as well? I think there's a lot that comes with that. So great opportunity. I think only time will tell.
And so just with the minute or so that we have left, I have appreciated a lot of discussion around strengths and assets in our rural communities. I think particularly as a rural researcher, 9 times out of 10 when we are funded to do research, it's to explore deficits. But I just want to tell you quickly about a study that we did. It goes back to some of our substance use work, but I think there are implications for all of the work that we do in rural communities. So we had observed that in eastern Kentucky, which has the highest overdose mortality rates in the United States, they were experiencing the steepest decline, actually, in overdose mortality. Not the place we would expect to see the steepest decline. Almost all of those counties are persistent poverty counties, and when we looked at the rate of decline in overdose mortality for every county in the United States, 3,154, what we found was that 8 of the 10 top counties were all clustered in eastern Kentucky, and all of them were persistent poverty counties. If you're not familiar with persistent poverty, that means that these are counties where more than 20% of the population has lived below the federal poverty line since the 1980 census and every census since. So when we're talking about intergenerational poverty, we're talking about counties that have lived in deep poverty since the 1980 census, 90, 2000 on up. We've received funding from CDC to go into those communities and see what are you doing right. And essentially what we found, it was communities coming together. Everybody in the community had been impacted. Everybody had a stake in seeing it improve. Nobody wanted to see their children, other people's children's dying in the communities anymore. They created social networks. What we call now a recovery ecosystem. They created immediate access to treatment. They expanded Medicaid, included a treatment benefit that now if you want to get into treatment in eastern Kentucky, you have a 1-hour wait. Where I live, across the border, we have a 5-month wait. A lot of people die in 5 months. 1-hour wait. And then they made sure they got employers engaged to hire people and give them productive opportunities moving forward. They got the judges engaged to send people to treatment instead of an incarceration. It was an all-community approach, and I think that can just be applied to so many of those other issues. And it's a story I love to tell, because when we tell the story and it's coming from Minnesota, everyone goes, yeah, but they're the healthiest state in the nation. We can't do that. But in Kentucky, if they can do it there, we can all do it. So I think it makes it attainable. So I will leave you with that and hand things back.
Thank you so much. Great example. Thank you to our panel.